Hello, my name is Dr. Arthur House. I am a specialist surgeon that works in Melbourne, Victoria, Australia, and I'm also the Chief Assessor for the Respiratory Functional Grading Scheme. Today's webinar is about the Respiratory Functional Grading Scheme and what it is. It's also about how we perform the grading, and it's to discuss what do the results mean. So this is a dog that presented to my practice. And this is a reason that internationally we've been looking for a system to be able to assess severity of the disease in dogs so that we can effectively eliminate this problem, brachycephalic obstructive airway syndrome, from these dogs. And as you can see, this dog is in severe respiratory distress, and this is after a 45-minute drive in a car that was air conditioned. And the reason the dog is distressed is that it became anxious, and it happens to also have brachycephalic obstructive airway syndrome. Now, brachycephalic obstructive airway syndrome, we need to talk about what that is. Now, very firstly, though the name says brachycephalic, not all brachycephalic dogs have obstructive airway syndrome. Some have mild disease, some have moderate disease, some are severe, and some don't have obstruction at all. The other consideration is that the disease is I guess, very well recognised and in the public arena. So most of us are aware that the disease is to do with the shape of the skull and the anatomy within the mouth and the nose. Particularly, we're aware of the stenotic nares, or the small nostrils, and the long soft palate. The reality is that brachycephalic obstructive airway syndrome is a very complex disease with numerous anatomical anomalies or variations, and also dynamic components that develop over time. This image here is a cross-sectional CT of a pug's skull, and it shows very clearly how complex the disease process can be. So here on the left is the nose, and we have stenosis of the external nares or opening, which we can see, but there is also in some patients stenosis of the internal nose. Within the nasal cavity itself here, we can have aberrant turbinates. Turbinates are air filters and present in all dogs, but in some short-nosed dogs, the filters don't fit or the turbinates don't fit, and then they become aberrant and are in the wrong position and obstruct the nasal cavity. Most of us have heard of a long soft palate, and that's relative to the size of the mouth. Many of the bulldog type breeds have a very large tongue, termed macroglossia. Some of the dogs have enlarged tonsils. Long-nosed dogs can have enlarged tonsils as well. It's just whether or not those large tonsils are occupying space in an already crowded throat. Rarely we'll see dogs with a narrow windpipe, which is termed a hyperplastic trachea, which is a very severe observation and can lead to really marked upper airway obstruction. Now, these are the fixed anatomical changes that can be observed in dogs who have brachycephalic obstructive airway syndrome, but dynamic changes occur. The one that's most commonly recognised is called laryngeal collapse, which is closing of the uppermost aspect of the windpipe when the dogs breathe in, and very recently described as pharyngeal collapse, which is closure of the back of the throat as the dogs breathe in. Really what this shows us is that brachycephalic obstructive airway syndrome is a complex disease with interactions between anatomy and dynamic function. So we have had a problem for a long time, and the problem was, how do we measure the severity of brachycephalic obstructive airway syndrome in the individual dog? Now, previously, it was based initially on historical assessment, so asking owners questions with regards to their dog's behaviour. Most of the questionnaires included whether or not the dog snored and the frequency, whether or not the dog had increased inspiratory effort or breathing effort, whether or not the dogs became stressed during exercise or intolerant, so unable to exercise, and a very severe observation would be syncope, which is collapse. So based on whether the signs were present or the frequency of the signs, an estimate of severity was given. However, the problem was that it was later shown that 60% of owners were either underestimating their dog's clinical signs or were not aware, even with dogs with very severe disease. And the reason for that is it was often considered normal for these breeds to snore or not exercise, and often the owners did not have a reference with regards to a dog who didn't have an upper airway obstruction. In conjunction with the historical assessment was then visual assessment, so looking at the anatomy. So we would look at the external nose and see if it was stenotic. We would then anaesthetize the patients and look at the length of their palate. We would assess laryngeal function, see if they had large tonsils. Problem here is that anaesthesia is required to do the oropharyngeal examination, so to look inside the mouth. And we know that there is, with regards to anaesthesia and brachycephalics, there's an increased risk of anaesthesia-related death. And in papers that look at anaesthesia in combination with airway surgery in these breeds, that risk is somewhere between 2 to 3%. So though a low risk, it is something that we have to consider. We can use tools to measure anatomy, so radiographs or CT can be used to measure the width of the trachea to determine if a dog has a very narrow trachea or a hyperplastic trachea, and we can use CT or rhinoscopy, so a camera in the nose, to determine if their turbinates are aberrant. The challenge we have, though, is that the anatomy poorly correlates with the severity of the dog's upper airway obstruction. Essentially, all bulldogs, all short-nosed dogs, so there's bulldogs and pugs and griffons, etc., have a relatively long, soft palate. Many have narrow nostrils. Many have enlarged tonsils. And the length of the palate or the degree of the narrowing of the nostril doesn't correlate well with the severity of the upper airway obstruction. There are vets who offer to anaesthetize dogs and examine their throat and their laryngeal function and their nose to give an estimate of the dog's brachycephalic obstructive airway severity. Unfortunately, this is a fundamentally flawed approach because we don't have the correlations between function and anatomy. With regards to the correlations between anatomy and function, it certainly has been shown that dogs have more severe upper airway obstruction if they have a thicker soft palate, but there hasn't been a correlation with a longer soft palate. If they have laryngeal collapse, though there's some papers that say that that doesn't change severity, but the majority do say it changes severity. And we know that certainly hyperplastic trachea is associated with very severe presentation. But the message here is that not all brachycephalics have brachycephalic obstructive airway syndrome, and anatomy doesn't predict the level of severity accurately. Happily, and fortunately for us, a functional assessment has been developed. So work with from Cambridge University in conjunction with the UK Kennel Club developed a functional, an objective measure of respiratory function. So using a tool called whole body barometric plethysmography, which is a tool in the medical world to assess respiratory function in humans, they were able to adapt that system to allow measures of respiratory function in dogs. So using whole body barometric plethysmography, Cambridge University was able to develop what was called a BOAS index, which is a mathematical measure of respiratory function from 0 to 100, where 0 is no upper airway obstruction at all, and 100 is the worst upper airway obstruction. And based on that, they were able to develop a functional grading system using whole body barometric plethysmography, which led to the capacity to accurately differentiate between those dogs that did have brachycephalic obstructive airway syndrome and those dogs that did not. So this test is all about function, It does not try to correlate to anatomy or to measure the anatomy. Now, the problem with whole body barometric plethysmography is it's not a useful tool in a clinical setting because it is a challenging tool to use. Mostly because the dogs need to settle in the box that's depicted in the picture, this perspex box, and breathe at a low respiratory rate. So if they're panting or anxious, the test doesn't work well. But again, fortunately for us as clinicians and individuals who are assessing these dogs, using whole body barometric plethysmography, Cambridge University were able to develop a very simple clinical tool for evaluating respiratory function, which is called the respiratory functional grade. So the respiratory functional grade is a grade from 0, 1, 2, 3, so a 4-point grade, where dogs that are depicted as grade 0 are brachycephalic obstructive airway syndrome free, grade 1 are clinically unaffected with mild respiratory signs, grade 2 are those dogs affected with moderate respiratory signs, and grade 3 are dogs that are affected with severe respiratory signs. And this respiratory functional grade was validated using the whole body barometric plethysmography, which is an objective measure of function. So how is a respiratory functional grade done? It is very simple, which makes it an extremely useful clinical tool. So the dogs are initially examined prior to exercise. They're allowed to calm and settle in a stress-free environment. Once they're assessed after they've calmed, they're then trotted at 6 to 8 kilometres an hour for 3 minutes, and the duration is particularly important. If the dog has reasons that it cannot manage this pace, so it has concurrent osteoarthritis or it's obese or very anxious, then a fast walk is attempted. After the dog is exercised at the end of 3 minutes, a repeat evaluation is performed of its respiratory function. Functional grading, so the grading is assigned based on respiratory signs before the exercise, during the exercise, and immediately after the exercise. And the highest grade of any of these signs is given as the final grade to the dog. If the dogs are under 12 months old, when they're first graded, they need to be regraded at a year of age. And the reason for this is that we know that brachycephalic obstructive airway syndrome progresses as the dogs mature. So if we grade them too young, then the grade that's assigned may be an underestimate of the dog's actual end point degree of obstruction as it matures. So this is the algorithm that's used. So we look at respiratory noise, we look at inspiratory effort, and we look for dyspnea, syncope, or cyanosis. So for example, if a dog is grade 0, it has no audible noise before exercise or after. It has no increased inspiratory effort before or after exercise. Now, when we're assessing respiratory noise, we use a stethoscope to auscultate the larynx. So that is no audible noise on auscultation of the auscultation of the larynx. With regards to a grade 3, the other end of the spectrum, they would have moderate to severe respiratory noise before the exercise and severe respiratory noise after the exercise. There are different styles of noise that can be heard, which are termed stertor and stridor. Now, fortunately, again, for us as clinicians, Cambridge has developed a series of videos which are examples of dogs in all 4 of these grades. So we have a visual reference to use as a guide when we are grading the dogs. Dogs with dyspnea are automatically grade 3, so dyspnea or cyanosis. So dyspnea and cyanosis is not seen in grade 0, 1, and 2 dogs. Dogs with severe inspiratory effort or moderate before the exercise and severe after the exercise are automatically grade 3. So grade 3 dogs, as earlier stated, have respiratory signs. Grade 2 have moderate, grade 1 are mild, that it's not clinically relevant, and grade 0 are normal. In tandem, so concurrently, we do a nostril assessment. It is part of the respiratory functional grade, but the nostril assessment does not determine the grade. It's the respiratory noise, the respiratory effort, and whether or not dyspnea or collapse is observed. But as with the assignment of a respiratory functional grade, Cambridge has provided these visual reference charts, so this time a chart rather than a video. So here it is on the left for pugs, French bulldogs and bulldogs. And at the top is an open nostril, and at the bottom is a severely stenotic nostril. So during the respiratory functional grading assessment, the dogs are also assigned a grade with regards to their nostrils, but that doesn't determine the respiratory functional grade that's assigned. It just tells us that the dog has mild stenosis, moderate stenosis, or severe, or an open nostril. Once the respiratory functional grade has been determined, then it will be lodged on the ORCID platform. That is a requirement of the grading system. The grading system is a collaboration or a contract with the UK Kennel Club, and they are collecting the data as the respiratory functional grades are done. And the reason for that is to allow us to document whether or not we're improving the breeds over time using the respiratory functional grading and good selection processes with regards to dams and sires. With regards to those grades that are assigned and then registered on the ORCID platform, the owner of the dog has the choice as to whether or not to make that grade accessible to the public or to keep it private. With regards to the grade assigned, what does that mean from the perspective of breeding? Well, grade 0 and 1 dogs are the ideal dogs and the preferred dogs with regards to utilisation for breeding programs. Grade 2 dogs can be used for breeding, but with caution, and ideally should be used with a grade 0 or a grade 1 dog. So if you have a grade 2 sire, then you'd want a grade 0 or 1 dam. Grade 3 dogs should be excluded from the program, and grade 2 dogs, we should avoid breeding then with grade 2 dogs. So how and where do I get my dog assessed? Well, vet assessor training has started. The first session was 16th of December 2022, and the aim is to train vets around Australia, so there are plenty of vets available who can do respiratory functional grading. There are several specific questions that have been asked, and the first, which is really important, is will all of the brachycephalic breeds be accepted for testing? If not, which ones? At this stage, the system has been validated for pugs, French bulldogs and English bulldogs, and they're the ones that can be assigned a grade from 0, 1, 2 and 3. Other brachycephalic breeds, what we can do is still do the respiratory functional grading, but we will only be able to assign BOAS positive or BOAS negative scores. Validation of the system is being done at Cambridge presently at this stage for other breeds of dogs. Will non-ANKC or Dogs Australia dogs be accepted? The answer is yes. The respiratory functional grading is available for all dogs, but the results will be recorded on the Dogs Australia ORCID platform. What will the cost of testing be, and will it be set by the vets, and therefore will it vary between vets? Yes, the cost will be set by the assessor, the vet. At this stage, it appears that the cost will be approximately $150 per assessment. Will there be easy accessibility to testing in regional areas? The answer to that is hopefully. That is our aim, and that is why we are training as many vets as possible. And will there be testing days at shows, for instance, available? And the answer to that is yes. And the first testing day was performed just recently. Very specifically, what effect and consideration will be given for speed of movement, ambient temperature, whether a dog is fit or unfit, a dog over or underweight or anxious? Well, the speed of movement is set at 6 to 8 kilometres an hour unless the dog cannot manage it because of other factors, and then we walk them as fast as possible. In reality, what we're trying to do is convert the dog to open mouth breathing. having done hundreds of respiratory functional grades, it does appear to be a very robust system. So if you can trot the dogs as fast as possible, you get a very good indication of their respiratory function. With regards to ambient temperature, though this is not set, but it is recommended that the dogs are tested at less than 25 degrees because it helps differentiate between upper airway obstruction, which is what we're trying to assess, versus heat intolerance and panting. All dogs pant when they get hot, and that can be sometimes a bit tricky to differentiate from the noises of upper airway obstruction. Ultimately, we exercise the dogs as close to the speed as possible. Can or should dogs be medicated during testing? At this stage, the answer to that is no. We need to see the dogs without medication. Is testing mandatory in Australia? At this stage, it's not. It is a choice. And in saying that, and in similar vein, the requirement to make the grade public is still your choice. You can keep it private. Is there a minimum age and a maximum age? And does one assessment last a lifetime? The minimum age for us to assign a grade, which is then put on ORCID, is a year of age. So we won't be doing grading assessment in dogs less than a year. The grade lasts for 2 years. There's no maximum age. We recently assessed a dog, a pug, who was 10 years old, and it had actually a remarkably low grade. So age is not an issue. Is there an appeal process? And if so, how will it work? Yes, there is. The appeal process is that I will assess the dog and assign a respiratory functional grade, and that assessment will be final. A more scientific question is, does respiratory functional grading replace tracheal measurements? Now, with regards to tracheal measurements, this arose out of a paper from Harvey and Fink in 1982. What they did is they measured the width of the trachea relative to the width of the thoracic inlet. And what they recognised is if the ratio between those two was less than 0.12, then the dogs had a very poor prognosis in that they would have severe upper airway obstruction or BOAS, and they had a high tendency to develop pneumonia. In reality, dogs with hyperplastic trachea, so a trachea with a ratio less than 0.12 is considered hyperplastic. They have a very poor prognosis, and many of those dogs die within the first year of age. What's really important to understand is that was a binary measurement. You're either greater than 0.12 or less than 0.12. It's not a linear association. So as your trachea gets wider, your respiratory function does not necessarily improve. So respiratory functional grading will identify dogs with very poor respiratory function and upper airway obstruction. So by virtue, it is highly likely to identify dogs with a hyperplastic trachea, but it doesn't assign a value. So radiographs and tracheal measurements will allow us to directly identify dogs with hyperplastic tracheas. If we had to choose the test, then we would do a respiratory functional grading only. If we have the luxury of doing both tests, then there's value in both. So hopefully this webinar has allowed some understanding of what is the respiratory functional grade. It is a validated grading system that allows us to determine a dog's function. And what we mean by that is, do they have brachycephalic obstructive airway syndrome? And if they do, how severe? It's not an attempt to correlate to anatomy, and anatomy does not give us a good estimate of a dog's function. How is it performed? It's very simple. It's assessment of respiratory noise, respiratory effort, and whether or not there's evidence of collapse before, during, and after a 3-minute period of exercise. What do the results mean? Dogs who have no evidence of brachycephalic obstructive airway syndrome or mild clinical signs are the ideal dog for breeding programs. Dogs who have moderate or severe are those dogs who are actually BOAS positive. The dogs who are moderate, so grade 2, should be used with caution in breeding programs. From a clinical perspective, dogs who are grade 2 or 3 need to seek veterinary intervention. I hope that was helpful, and thank you for listening today.